Hello and welcome to this episode of our Rhinoplasty for Residents and the Foundations of Facial Plastic Surgery webinar series. We really hope you have a great time watching this show.
Okay, is my screen shared there?
Yeah, it's looking good. Yeah, thank you, Hamzah.
Okay, good. Yeah, thank you very much, Deepak. That was excellent and sort of brings back memories of lots of debates and discussion in the Joel Stein theater complex about some of those points. So I want to take you through a sort of journey through lower eyelid blepharoplasty. And once again, I'm going to focus on the points that our mentor, Robert Goldberg, sort of took us through. It's a lot of his experience and advice over time has led us to, using more minimally invasive techniques and avoiding some of the complications. So just in terms of the outline of today's talk, what I'm going to do is touch a bit on facial aging in the lower eyelid. And then we'll review some of the anatomical concepts around lower blepharoplasty surgery, then looking specifically at surgical technique and then how to avoid the complications. So just as Deepak was talking about the upper eyelids, what causes these lower eyelid bags? And you should have a systematic approach to how you address these patients from a cosmetic sense. So things like the skin quality, the color, elasticity, presence of fluid, dynamic lines are all important. As well as the lower orbit 3D contours. So it's very important to have an appreciation of the three-dimensional view of a patient, as well as the volume status. So looking at where the facial structures have become devoid of volume versus bulging volume. So just looking at rethinking our previous understanding about the aesthetic of orbitofacial surgery. So just go one slide back, sorry. So previously they used to think that upper eyelid fat and skin were excessive as you aged, and that lower eyelid fat and skin also became excessive. The eyebrow droops, the midface droops, and the muscles become overactive. And over time, we've tended to question these paradigms. And what we've seen now is that eyebrow fat pad deflates and the skin actually loses turgor. I know Dr. Goldberg used to preach to us that there's no tissue that gains as time goes on. Everything atrophies. So why would the skin become excess? The periorbital hollows and loss of skin elasticity are what causes the eyelid bags, lower eyelid bags. And the eyebrow fat pad and temporalis deflation is what leads to the eyebrow droop. And there's loss of soft tissue and bone volume in the cheek. And the skin loses the ability to fight back against muscle. And so orbicularis muscle is not becoming overactive. It's just the skin's ability to fight back against it. So redefining the anatomy of aging. So we look at the facial hollows. And when you look at the lower eyelid midface complex as you age, there's sort of key aesthetic concept here is that when you're younger, the single convexity of youth shows the sort of smooth interface between the cheek and the eyelid, lower eyelid. And as you age, you get this double convexity formation. And so you can see here the smooth interface between the cheek and the lower eyelid in this patient when he was younger. And loss of midface volume coupled with orbital fat herniation results in the appearance of these lower eyelid bags. And so that smooth interface is disrupted. Furthermore, when you look at where the volume changes are happening, you can actually pick out that you're seeing the orbital rim hollow as one of these landmarks. The other is the septal confluence hollow and the zygomatic hollow. So soft tissue loss then occurs at sites where the ligaments attach to the skin. So as I mentioned, the orbital rim ligament, the zygomatic ligament, and the septal confluence. And this series will show you exactly those anatomical landmarks. And so the septal confluence hollow can be seen there at the border between the pretarsal orbicularis and where the septum attaches onto the lower eyelid. And this is uniform. You'll see this in all these patients who present with these aging changes. And so the goal is to restore the congruity of the lid-cheek junction, as in this patient here. So the question now, what are the options for filling these facial hollows, and should you fill or remove volume? And so there are many different techniques that can be used. So fat injection, fat transfer preservation, lifting the midface, putting implants in the midface, and the use of synthetic fillers, which has become popular now. But I'm going to concentrate on the surgical concepts here. And so there's a few anatomical considerations to take in to play. So one is the orbital fat prolapse. So this has a characteristic shape and it's delimited by the orbital compartments, which I'll take you through now. The central fat pad is this cigar-shaped fat pad, and its prominence increases in upgaze. And this is how you know that you're dealing with orbital fat prolapse. So as you can see in this patient on downgaze, the effect is minimal, but on upgaze, as the eyeball rotates and shifts the dynamic of the orbital fat contents, you can see prolapse of the fat. And so if we look anatomically at these, what separates these? One is that you get an arcuate expansion that extends out laterally, and then extensions from the inferior oblique extend out medially. And what this does is it separates the medial, central, and lateral fat compartments. So another anatomical concept is trying not to think of these fat volumes and spaces in 2 dimensions. And so if you look at this picture, you get the impression that the fat pads are sort of just at the edge of the orbital rim. But this is not true. You got to think of the orbit in 3 dimensions, because the orbit and the facial structures are 3-dimensional. And so it's important to understand this concept so that you can access these fat pockets appropriately. So the medial fat pocket is actually found just behind the origin of the inferior oblique muscle, so it's within the orbit. And so when you're dissecting out, it's important that you dissect inside the orbital rim in order to access this fat pocket appropriately. Similarly with the lateral, is actually found higher and more posterior than one normally thinks. And this is often a point of difficulty for a lot of surgeons, in that patients return with these residual lateral fat pockets, because often there's a fear to go to access the fat pocket appropriately. And so once again, dissection needs to be within the orbital rim. It's actually found just behind the canthal ligament detachment. The central fat pad is probably the most easiest to access, but once again, just sits inside the rim. And so this sort of anterior-posterior dissection with your scissor will allow the fat to herniate appropriately. So you can see from this series of videos here, you have to go accessing the medial fat pocket, just inside the orbital rim, with blunt dissection, just past the origin of the inferior oblique, as shown in the picture here. And then once you open the fat pocket, you can see the prolapsing fat, which can then be trimmed off as needed. Similarly, looking at access to the lateral fat pocket, so conjunctival incision out laterally. This is advanced just past the orbital rim, and you can see just past at the level of the insertion of the canthal tendon and deep to that. And so there's the lateral fat pocket prolapsing, and then this can also be trimmed as necessary. Dissection of the central fat pocket using the anterior-posterior dissection technique. Just on the orbital rim exposes that pocket. So in summary, the 3 fat pads have to be looked at in 3 dimensions. So the medial fat pad is deep to the inferior oblique origin. The lateral fat pad is deep in orbit and higher than you think. And the central fat pad is fairly anterior but beneath the orbicularis. The question is, do you have to remove this fat? I mean, is that the only surgical approach to addressing the double convexity, and in fact, no. So depending on the patient and your assessment of the patient, there are many ways you can address this. So one is obviously with simple fat excision, and this is preferable for patients who've got, a good midface volume. But a lot of your patients are not going to present with good midface volume, and one of the dangers is with simple fat excision is that you can actually accentuate the double convexity formation. And so the concept of not removing the fat, but rather transposing this fat to achieve a better, smoother lid face junction has been proposed. And so you can see in this animation that the traditional blepharoplasty addresses the blepharoplasty fat pockets, and what it can actually do is accentuate this double convexity. And that's seen in this patient here. So came in for lower eyelid blepharoplasty, had fat removal, and here you can see the accentuation of the double convexity. And so the concept behind fat transposition blepharoplasty is, instead of removing the fat, to rather tease the fat out into pedicles, which can then be placed either in the suborbicularis plane or in the subperiosteal plane, depending on the technique you prefer. And so here's an example of a patient who has got this lower eyelid bags, double convexity, and he's had a fat transposition blepharoplasty. It's a much nicer, smoother interface between the cheek and the lid. And just an anatomical diagram showing the subperiosteal dissection, and just to be careful of the infraorbital nerve as it emerges. And so my preference is a suborbicularis dissection, because then the infraorbital nerve is subperiosteal, so this is less likely to get injured. Here showing again the formation of the pedicles and the tucking in of these pedicles in the flap created. And so this is a video of the fat transposition blepharoplasty, this local injection. Here using a cautery to incise the conjunctiva. So what we see here is at the arcus marginalis, the orbicularis inserts there, and this can just be divided off, which can either be done by blunt dissection or sharp incision. And then blunt dissection is carried out further past the orbitomalar ligament. The fat pedicles are created from the central, lateral, and medial fat pockets. And the 4 chromic sutures passed, tied on to each end of the pedicles, and advanced down onto the malar eminence. Here we're using a bolster just to prevent the dimpling of the skin. And the concept behind this is that you stretch out the fat across these things. So you don't want the fat to concertina when it's placed in the created pocket. And so here's an example of a patient preoperatively and 5 months post-surgery. Once again, another case of transconjunctival blepharoplasty and fat repositioning. Once again, you can see the loss of the malar volume, and the repositioning allows for a smoother lid-cheek interface. As Deepak pointed out, there are a lot of adjunctive techniques, so it's important to assess the patient in a total sort of way, from front to back approach. So here you can see the actinic skin changes, which you won't be able to address from simple fat repositioning or fat excision alone. And here, combined with a collagen synthesis procedure such as a TCA peel or even laser for this patient, gives you a more satisfactory result. Another patient here who had lower blepharoplasty, fat repositioning, and TCA peel. And just an example showing that you can actually use these adjunctives at the same time as surgery to give you a good result. Now, lastly, just looking at avoiding complications in blepharoplasty. So just as with upper blepharoplasty, lower blepharoplasty also has some of its issues that can become a nuisance for surgeons. And perhaps lower blepharoplasty more so than upper blepharoplasty tends to be less forgiving than upper blepharoplasty. So we'll go through issues such as chemosis, the lower eyelid retraction syndrome, patients who present with double vision post blepharoplasty, and what constitutes high risk procedures. Well, you know, what techniques are more likely to cause these complications, and which techniques are less likely, and can we accomplish this with a combination of low risk procedures? So as Deepak also mentioned, the physiology of the eyelid interface is critical. And often patients who are unhappy post blepharoplasty, it's often due to disruption of the physiology of the eye. And so it may not be apparent when you look at them as to what's going on, but they're very symptomatic and can be really irritating for the patient. And so it's important that you understand the physiology of the surface of the eyelid, and that the tear film plays a critical role in this. And any disruption of the tear face and ocular surface is going to lead to an unhappy patient. So here you can see what the blink dynamic does. And so the blink is responsible for spreading the tear film across the eyeball. And so any disruption of this with your surgery, which leads to orbicularis paralysis even momentarily, can cause these symptoms. So the conjunctiva, what is it? Well, it's loose areolar submucosa. It contains many lymphocytes, and it's actually the lymphatic drainage system for the globe in the eye. And so any disruption of the surrounding tissues can actually cause edema or fluid accumulation within that, which causes the chemosis. But this tends to settle down with time, provided that the chemotic conjunctiva is not exposed. This is a slit lamp image taken looking at the eyelid conjunctiva or globe interface, and you can see there's no redundancy of the conjunctiva. It's a smooth plane. In this case here, you can see some redundancy of the conjunctiva in a patient with conjunctiva chalasis. A similar appearance would happen in a patient with post-blepharoplasty chemosis. The biggest problem that we probably see now is patients who have these post-blepharoplasty lower eyelid retraction syndrome. And here you can see the eversion of the lower eyelids as a result, and make out the subciliary incision on the lower eyelids here. And so this makes for very unhappy patients, because you can see increased scleral show and loss of protection of the lower globe. And so why does this happen? Well, one is that going through the skin orbicularis causes a volume collapse. There's loss of the independent lamella of the eyelid. There's something called mid-lamellar shortening, which is something Dr. Goldberg sort of coined. Cutting through the orbicularis causes paralysis of the orbicularis, and removal of skin causes skin shortage. And so many of us have moved away from doing cutaneous incisions. There are very few patients who may actually need it, and the risk of causing skin shortening far outweighs the benefit of actually excising skin in this area. What about double vision after blepharoplasty? So, well, one thing is injury to the inferior oblique, which is the most dreaded complication. And diplopia or double vision is probably one of the most debilitating complications for a patient to undergo, because they basically lose functionality. They're unable to drive, unable to pour a cup of coffee because of the loss of the binocular vision. And so one of the issues is that aggressive fat removal and aggressive management of the tissues here results in loss of the fat buffer. And on this ultrasound scan, you can see there's a tethering of the fat as the globe moves. So which are the high-risk maneuvers for causing these problems? So as I mentioned, firstly, removing skin. So removing skin will often cause retraction issues post-surgery, and very few patients actually require removal of skin. Any interruption of the orbicularis muscle, cutting across the orbicularis nerve supply, and this would happen with a transcutaneous incision, and over-resection of orbital fat. So very aggressive resection of orbital fat will cause scarring of that middle lamella and contracture of the lower eyelid. So what are the relatively lower risk procedures? Well, one is transconjunctival fat debulking, or actually fat transfer. coupled with conservative exfoliation, which can be the peel or laser. For some patients, you may consider an orbicularis tuck or a skin pinch, with orbicularis preservation, where only a subcutaneous incision is done, trying to minimize any injury to the orbicularis. And you can get very good outcomes in these patients. So here's a patient with transconjunctival fat repositioning and TCA peel. But in some patients, you can see that just addressing these issues are not going to be enough. And so here, low blepharoplasty with a orbicularis sling and a skin pinch. So the orbicularis is sort of tucked up and rebolstered laterally, and only skin removed from the lower eyelid. Here you can see conservative fat debulking. And the nice thing about adjunctive techniques is that you can always add volume later. And that's one of the beauties of using hyaluronic acid gel in your practice. Here again, debulking of the lateral fat pad, repositioning of the central and orbicularis tuck. Patient had conservative fat debulking, TCA peel, and then HA gel at a later stage. So in patients like this, who you can see would do well with either debulking of the fat or repositioning, but still has malar hypovolemia essentially. And so he had midface HAG filling. So in summary, the lower eyelid has a delicate physiology, which is easily disturbed. And so avoid maneuvers like manipulating the septum, damaging the orbicularis, and over-resecting fat and skin. Cutting on the lower eyelid skin may not create as much as an improvement as we hope, and I think a lot of us have moved away from this. And a transconjunctival approach is fairly minimally invasive, and it's easy to approach the fat with conservative treatment is probably the safest way to go. Thank you.
Hamzah, thank you very much. I really enjoyed going through all the steps again. It's so interesting to look at the plastic surgery world versus the oculoplastic surgery world. And I was thinking about a basic question before Cameron gets in with his questions. I just want to pop one question. The dreaded complication of blindness after surgery has been something that everybody has spoken about. Would you like to just briefly mention why it happens and what the real incidence is and what we tell patients before the time?
So what, you're talking specifically with surgery itself?
We're talking surgery.
Yeah, so with surgery, the cause of blindness is usually a retrobulbar a hemorrhage, which occurs acutely. And so the risk is probably higher with lower blepharoplasty than with upper blepharoplasty, but can occur in either. But so a lot of surgeons are very particular about cauterizing the fat before they excise it. So some will actually cauterize the fat over a wooden cotton stick, or may actually bipolar the fat prior to cutting through the fat. Interestingly, where I trained, Dr. Goldberg actually never used cautery. He would trim the fat with scissors. And I don't think we saw one case of retrobulbar hemorrhage during that time. And so one of the things that when you do the transconjunctival incision, we don't tend to suture that incision. And so I think part of the benefit there is that the blood has an avenue for escape should they develop a retrobulbar hemorrhage. And so the most important thing is counseling. I mean, it's a rare complication, but you need to provide the patient with an avenue for accessing care. So oftentimes, why these complications happen is that the patient goes home, develops the complications unaware of what's needed to come in, because they may still be anesthetized or whatever it is, So it's important for them to know the increasing pain, sort of to check, and if they notice any loss of vision, that they should present as soon as possible.
Thank you very much for that, Hamzah. Cameron, have you got any questions on your side?
The questions are rolling in here now. Hamzah, I don't know if you want to stop your sharing of your screen. You can always share it if you need to respond to any of the questions.
Sure.
So Ernest Moller wanted to ask you, everyone's saying great talk, by the way, so I won't carry on with that. He'd like to know, how often do you combine a canthopexy or canthoplasty, and what is your indication?
That's a very good question. I just want to stop sharing my screen. So that's a very good question. And one of the things that you need to assess for preoperatively is whether a patient has any horizontal laxity. From our teachers oculoplastics, doing a lateral canthopexy or orbicularis sling or anything laterally is often a defensive technique. And it's often done for patients in which there's a through a transcutaneous incision is done. And so we hardly ever do it for a sort of transconjunctival blepharoplasty alone. There's some patients who will benefit from what we call minimally invasive canthoplasty, where through an upper eyelid crease incision, through your upper eyelid blepharoplasty incision, you can actually access the lateral canthal tendon and sort of plicate it or do a pexy, essentially. Is one combination we have used, but that's often in a patient you've preoperatively assessed as having lateral laxity. We never do it sort of on table as a defensive.
Thank you. Then 2 questions from Phil Pierce. He'd like to know any tips to avoid post-op chemosis.
That's a difficult one. I think some patients are prone to it and some not, so you may get 1 out of 10, 15 patients who may get chemosis. The key thing there is not to panic. I think a lot of people then end up doing tarsorrhaphies and lateral canthal suspensions to try and relieve that. And the key issue there is that the chemosis will settle as long as the conjunctiva hasn't prolapsed past the eyelids, And so as long as we often give steroid ointment or steroid eye drops post-operatively. This tends to help. And if not, you can actually just pad the eye closed. As long as there's the conjunctiva is behind the lids with some pressure, that chemosis will get better.
Good, thank you. He's got a second question. Do you ever combine some fat excision with transfer in cases with a lot of fat?
You could do that, but I don't know. Deepak can also comment. I've never seen a patient where you would have too much fat to transfer. Often these patients have quite a lot of volume loss, and the thing is, when you transfer the fat, I don't think all of the fat actually ends up taking. There's some contracture of that fat just from the surgical manipulation, and so when we do transfer the fat, it's not an overly impressive volumization of the cheek. It just sort of improves the interface between that lid and the cheek. So, but yes, I mean, I suppose you tailor it to the patient. There's many ways to skin a cat, sort of, So if you do have a patient with excessive, you can trim and reposition fat.
Deepak, do you have any comments there? Eh?
Yeah, I would say that the patients who I have found subpar results with fat transposition are patients who have poor midface projection. So Asian patients in particular, or just patients who have maxillary retrusion, I find that you really don't get a great result with fat transposition. And I'm more inclined to do fat transfer for those patients because I can really reduce the volume in that pre-tarsal area and add the volume across the entire midface, as they need.
Cool. Okay. Another question here from Manoj would like to know what corrective procedure would you suggest for ectropia?
For ectropion?
Yeah.
Well, I think it depends on the cause of the ectropion. The most common cause of lower eyelid ectropion is going to be senile or atrophic ectropion. And that's often a combination of horizontal laxity of the eyelid as well as retraction of the lower eyelid retractors. And so you need to assess the patient for that. But the most common procedure that in my hands is the minimally invasive canthoplasty, where there's no disruption of the lateral canthal angle. But I think the most people would use a tarsal strip procedure or any other eyelid horizontal shortening procedure for that.
Cool. Okay, another question here. I'm just going to try and so do you release, this is from Ramath, do you release the arcus marginalis to release the skin depression? If that makes sense.
You mean when we're doing the fat transfer, I'm assuming?
I assume so. That it's quite an ambiguous question there.
Yeah, I mean, the arcus marginalis is ligamentous structure at the orbital rim. So I mean, if you're doing a subperiosteal incision, then you're obviously going to incise periosteum at that level. But I tend to do a orbicularis dissection. So you can actually strip off the orbicularis at the arcus marginalis. And I think what he maybe is alluding to is dissecting past the malar ligament. And so we do release that to try and get the fat pocket in there. But I think there's some benefit in releasing that malar ligament anyway. I think that's what causes that. It's at the ligamentous attachments that we see the convexity formation with volume changes across that ligament.
Okay, I think we've finished with the questions for now.
Can I just interject here, please? We haven't covered festoons of the cheek, and I suspect we're going to do it in the midface part. But I thought I'd give both of you an opportunity to comment on that. Do you ever treat festoons? What's your favorite techniques?
The festoons are a tricky one. It's, I mean, there are various techniques. One is direct excision of the festoons. But I tend to favor skin resurfacing procedures for this. I think doing a direct excision never gives you a great cosmetic result. And oftentimes it tends to recur because the true question is what's causing the festoons, and often these patients have an element of edema of the skin, whether there's some kind of dermatitis involved, like you see with rosacea patients. And so I tend not to do an excision of the skin. I think you'll find yourself in trouble more often than not. So oftentimes it's addressing the skin issues. If they've got rosacea, then I'd often, send them to dermatologists for treatment of rosacea. But you can often combine it with laser, skin resurfacing procedures is what I would sort of prefer. There are some patients, typically you'll see this in these elderly gentlemen who sort of, as much as I don't like to take skin from the lower eyelid, there's just no way you can avoid it, And so there are various techniques in which you would do that. One interesting concept was from Don Hudson at our plastics department is actually to do subcutaneous dissection and relay the skin over without taking any skin, because doing that will actually cause some contracture of the skin itself, so, but you're not excising any skin there, So I see Phil here says that he finds that fat transposition sometimes helps with those festoons.
I wonder if releasing the ligaments don't help with that, because the ligaments kind of, everything dams up against the ligaments.
Yeah, and I would agree with you. I think if the fat transposition is helping in those patients, it's probably from the releasing of that malar ligament.
I like that very much. Thank you. That was my question. Cam, shall I call an end to the meeting?
Yeah, so just before you do that, from my side, I just want to say thank you very much to both of you guys, and thank you to everybody who's been on. Next Sunday, this coming Sunday, okay, in a week's time, we're going to have a fantastic lecture about patient psychology and rhinoplasty. So it's titled How to Understand Our Most Difficult Patients, Surgical Body Dysmorphic Disorder by Mark Constantian over in the US. So I'm really looking forward to that. I think you're going to learn a lot from that. So, just a shout out, that's next Sunday night at 8 o'clock.
Thank you, everybody, for attending. And Cameron, I must tell you, I'm not sure that you can understand that lecture, but good luck. Goodbye, everybody. Thanks very much for attending. And thanks for everybody who helped and who led the talks. Bye-bye.
Thanks, Deepak. Cheers. Bye-bye.
See you later.